Um, Welcome to the Yale ASH 2021 highlights. My name is Bob Bona. I'm one of the hematologists at Yale, and I'm happy to facilitate this session today as we are focusing on some of the important abstracts from the previous ASH meeting relating to classical hematology. And today we have three presenters who will each present abstracts for about 15 minutes. We'll take questions at the end of the session, and they should be entered into the chat room or to the Q&A. Before we start, let me take a moment to introduce our presenters. First, Kelsey Martin, who's an assistant professor in clinical medicine at the Yale School of Medicine, and she practices hematology oncology at the Orange Care Center and has a special interest in classical hematology, and particularly the intersection of obstetrical care and hematology. Dr. Sudhanshu Mulay, who's the medical director of the anticoagulation clinic at St. Francis Hospital and Medical Center. And he also has a strong interest in classical hematology and transfusion medicine. He's an assistant professor of medicine at the University of Connecticut. And then finally, Dr. Alex Pine, who's assistant professor of medicine and hematology at the VA Medical Center. He and his colleagues have done significant work over the past few years detailing the mechanisms of COVID coagulopathy. So without further ado, I'll introduce Dr. Martin and let her begin the presentations.
Great, thank you so much. Good afternoon, everyone. Is my volume okay? Perfect. All right. So I'm going to be discussing three abstracts relating to bleeding disorders. First abstract is titled Efficacy and Safety of Fitusiran Prophylaxis, a small molecule RNA interference therapeutic in a multi-center phase 3 study called ATLAS-INH in people with hemophilia A or B with inhibitors. This was presented at the plenary scientific session by Dr. Guy Young from University of Southern California. First, I'll provide some background. Hemophilia A and B are rare bleeding disorders that are characterized by ineffective clot formation, largely due to impaired thrombin generation as a result of severe deficiency of factor 8 and 9. Currently, our standard of care largely relies on replacing the missing factor. There's a high rate of development of anti-factor inhibitors, which is up to about 30% in some of our patients with hemophilia A, and about 5% of patients with hemophilia B. Subcutaneous fitusiran is a novel therapeutic. It's a small molecule RNA interference therapeutic that acts by binding and degrading the mRNA, which encodes for antithrombin, thereby partially silencing the expression of antithrombin. This rebalances hemostasis and restores thrombin generation in patients with hemophilia A, and has been demonstrated to be effective in patients with or without inhibitors, as I'll discuss. This study demonstrated that prophylactic use of fitusiran significantly reduced annualized bleeding rates, which is essentially bleeding events on an annual basis in patients with hemophilia A or hemophilia B that have inhibitors, and demonstrated both efficacy and safety data. In this study, 57 patients were randomized 2-to-1 in an open label phase 3 trial. Patients were males over the age of 12, again with either hemophilia A or B with inhibitors. And these were patients that had been receiving on-demand treatment with bypassing agents for breakthrough bleeding. There were 38 patients in the fitusiran group, and the dosing of this this is a subcutaneous therapy that was given at 80 milligrams once a month versus 19 patients in the on-demand bypassing agent group. They were followed, the primary endpoint was looking at annual bleeding rate in the efficacy period, which was 9 months. Secondary endpoints looked at spontaneous bleeding rates, joints, bleeds, quality of life metrics, which by a validated quality of life tool, and also frequency of the bleeding episodes that happened in the onset period, which was the first month of therapy, as well as safety and tolerability data. And this was demonstrated to be extremely effective in the fitusiran patients. So you can see here on this first line, the median annualized bleeding rate was actually 0. The estimated rate was 1.7 versus in the bypassing agent group, the median annualized bleeding rate was 16.8. And there was actually the median for spontaneous bleeds was 0 in the fitusiran category. There was also demonstration of significant quality of life improvements based on the validated quality of life screening tool. And it was effective in both patients with hemophilia A and in patients with hemophilia B. And we can see that 29 patients received fitusiran in the hemophilia A category, and 9 patients received it in the hemophilia B category. And again, this is compared with this second line here of a patient who received the bypassing agent only, with a very significant p-value. Overall, the agent was well tolerated, although the main side effect of special interest was thrombotic events. There was no deaths of any kind in either group of note. Of the patients that had thrombotic events, the authors reported that occurred in some patients that seemed to have the antithrombin levels at the lower end of the ranges seen, some as low as 10 to 20%, which is what they attributed to. And only one patient who had a thrombotic event ended up coming off study, and this was a patient who had a thrombosis in a spinal vein. Other side effects were increases in transaminases, but the authors reported that this did not impact any of the treatment scheduling, and no patients had to come off trial for any changes in hepatic enzyme changes. So the conclusions were that fitusiran had significant improvements in the treatment arm compared with the on-demand bypassing agents. This is seen as somewhat of a game changer in the sense that it's given monthly and subcutaneous, which is a tremendous change in compared to the current standard of practice, where patients are needing intravenous therapies and a much higher frequency. Nearly 2/3 of the patients treated with fitusiran had 0 treated bleeds, and the median annualized bleeding rate was 0. And of note, this is also efficacious in both patients with hemophilia and hemophilia B. And it's patients with hemophilia B have really had not had similar prophylactic options as our hemophilia A patients. So creating a new sort of treatment approach. 7 patients in the treatment arm had at least 1 adverse event, including the 4 thrombotic events, and 1 of those patients did require withdrawal from the study. That concludes my discussion on the first abstract, and I'll move on to the second. The second abstract was titled Rate of Prolonged Response After Stopping Thrombopoietin Receptor Agonist Treatment in Primary Immune Thrombocytopenia, Results from a Nationwide Prospective Multi-Center Interventional Study. And this was out of France. Some background information. There's been several retrospective studies and a recent prospective study that reported unexpected cases of durable remission after TPO receptor agonists were discontinued in adult patients with ITP. This has been seen in up to 30% of these patients. However, it's felt that perhaps some of the newly diagnosed ITP cases in which such spontaneous remissions occurred may have been included in most of these studies. So the question this study has is, what proportion of patients with either persistent or chronic phase ITP and no recent exposure to any potentially curative therapy, such as splenectomy or rituximab, achieve a long-term remission off treatment at 24 weeks and 52 weeks after having on at least 3 months of their TPO receptor agonist exposure, who had a complete response? And persistent phase ITP is defined as those with ITP between 3 and 12 months, whereas chronic phase is lasting for beyond 12 months. So the inclusion criteria, so again, this was a nationwide prospective multi-center interventional study. The inclusion criteria included patients over the age of 18 with either persistent or chronic primary ITP, They needed to have a stable, complete response, which was defined as a platelet count of more than 100,000 for more than 2 months on their TPO-RA therapy. And they needed to have been on treatment with their TPO-RA for at least 3 months. Exclusion criteria was patients who were on either anticoagulation or antiplatelet therapy, patients who had previously failed the TPO-RA agent. The patients could not have been receiving any concomitant steroid, corticosteroid, or IVIG, and they could not have had rituximab nor splenectomy within either the 2 months preceding or after initiation of their TPO-RA therapy. And the patients underwent a progressive dose reduction, and their TPO-RA therapy had to be stopped by 10 weeks, and they proposed a method, whether it was a romiplastim or L-trombobag, of a protocol of how to taper off their doses accordingly. And if a patient relapsed after this discontinuation, the decision to start a new therapy was left at every investigator's discretion. And so the primary endpoint was what was the proportion of patients who achieved an overall response, which was defined as CR plus R at week 24, so 6 months afterwards. And the secondary outcomes looked at the overall response rate after a year, 52 weeks. They looked at patients who had bleeding events, and they aimed to try to identify any predictive factors to see which patients might be those who achieve such an overall prolonged response. So 49 patients, which included 30 females with either persistent, there was an N of 2, or chronic N of 47 ITP, the median age of 58.5 years, were evaluated in this 2-year period over 22 centers. 40 of the patients had received L-trombobag and 9 romiplastim. And the intention to treat analysis, 56.2%, so 27 of the 48 patients achieved the primary endpoint and maintained an overall response at 24 weeks after TPO-RA discontinuation. And of those, half of those, essentially 55%, 15 of those 27 had a complete response, which again is defined as a platelet count over 100,000. Bleeding events did occur in 61.9% of the patients and 65.2% of the patients who did relapse at the 24-week and 52 weeks, with a median platelet count of 31,000 at that time. No severe bleeding episodes occurred. And they could not identify any predictive factors, neither age, which agent the patient had, how long they'd had ITP. None of these things were able to predict which patients were those who were going to achieve such a sustained response. So the conclusions of this was that after 52 weeks, and this is you can seen by the diagram on the right-hand side, after TPO-RA discontinuation, overall response was seen in about half of these patients, 52.1%. For those who did relapse, the median time of relapsing after tapering was at about 8 weeks, but the majority of those actually happened within the first 2 weeks, and none of those patients who relapsed developed severe bleeding. And among 21 patients who did relapse before week 24, 13 of those were able to be re-challenged with their TPO-RA, and they were still able to achieve a complete response with a median time of 2 weeks. So the conclusion is that there was a high rate of sustained off-treatment remission after TPO-RA discontinuation in patients with chronic ITP who had initially achieved a stable CR. They were unable to identify a predictive factor of which patients would achieve such a lasting remission. But this study strongly supports use of a progressive tapering off of the dose of TPO-RAs in patients who do achieve a stable CR on treatment, and there may be opportunity for us to be able to discontinue therapy in such patients. The last abstract I'll discuss was called Obstetrical and Perioperative Management of Patients with Factor XI Deficiency, a Retrospective Observational Study. In the background information, data regarding obstetrical and perioperative management of Factor XI deficiency is scarce. And the question at hand is, can we create a database of such patients and identify factors associated with increased bleeding risk in patients with Factor XI deficiency during childbirth or surgery? And this was presented by Dr. Hanna from the Icahn School of Medicine at Mount Sinai. So they did a retrospective chart review of patients with factor XI deficiency who underwent either childbirth or surgical procedures over a 10-year period within the Mount Sinai healthcare system in New York City. And they collected data on age, sex, ethnicity, genotype, family history, personal history of bleeding, the type of anesthesia used, the estimated blood loss, and any evidence of periprocedural bleeding, which patients needed blood product administration, and which patients needed hemostatic agents in the perioperative period. They defined a bleeding endpoint as acute postpartum or postoperative hemorrhage, or any bleeding that warranted non-prophylactic administration of packed red blood cells, FFP, or tranexamic acid. They performed a logistic regression to test for the association between either historical, laboratory, and procedural variables with the bleeding endpoint. So overall, 198 patients were evaluated who had undergone 252 procedures in total. This included 143 vaginal deliveries and 64 C-sections and 45 other surgical procedures. 38 of the 252 procedures did result in bleeding complications. And they found that both a prior history of bleeding and a lower factor XI levels were independently associated with the bleeding endpoint. Interestingly, 8 out of 21 patients, 38%, who suffered a bleeding complication, this happened despite prophylactic FFP. The mean factor XI level for with patients who received neuraxial anesthesia was 50 units per deciliter. And 5 patients with a negative bleeding history, despite surgical challenges, were actually able to receive neuraxial anesthesia at factor XI levels less than 10 and without any bleeding complications. And only one of these had received prophylactic FFP. So their conclusions were that a personal history of bleeding was the strongest predictor of perioperative or obstetrical bleeding. And that personal history of bleeding was actually defined as just one report of heavy menstrual period or bleeding in the operative period. It just took sort of one event in time to define a personal history of bleeding. Factor XI levels were found to correlate with a slightly lower but statistically significant odds of surgical bleeding. And they found that a factor XI level cutoff of 40 units per deciliter may predict bleeding risk with reasonable specificity at 83%, but lacked sensitivity. They also found that factor XI levels are stable during pregnancy, as demonstrated by the diagram on the bottom right, showing that repeat measurements may not be necessary, which is something commonly done in practice. And they also found that neuraxial anesthesia appeared to be safe to use in this cohort, which clinically is a question that comes up frequently. I thank you for your time. I look forward to hearing from our next speaker, Dr. Mulay.
Thanks, Kelsey. All right, thank you for the opportunity to talk today. I'm going to focus on thrombosis. So I'm hoping to present 3 studies that I found of interest. I'll have one focus study, and then as time permits, I'll go through the other 2 studies a bit quickly. The focus study that I would like to present is one listed here by Mers et al. From the Brigham and Women's Hospital in Boston, who looked at anticoagulation use and outcomes among patients with atrial fibrillation and von Willebrand disease. So an oral presentation. The background is that estimated prevalence of symptomatic von Willebrand disease is about 1 in 1,000. It is estimated that patients with von Willebrand disease have similar prevalence of atrial fibrillation as general population, which is about 0.84%. The American College of Cardiology recommends using anticoagulation for those with atrial fibrillation who have a CHA2DS2-VASc score of 2 or greater in men or 3 or greater in women. The recent ASH, ISTH, NHF, and WFH guidelines recommend using anticoagulation or antiplatelet therapy as clinically indicated. It was a suggestion with low certainty of evidence. And importantly, when I looked into the actual basis of this recommendation, it was based on a case series of about 60 patients, so really low quality data. So the study that was presented was a retrospective study in which data was obtained from the electronic medical records. Patients were selected if they had a diagnosis of von Willebrand disease, low risk-seeking cofactor activity, or any abnormal von Willebrand factor measurements, and also selected for those who had diagnosis of atrial fibrillation. The primary endpoint was rate of major bleeding as defined by the ISTH criteria, which is fatal bleeding, bleeding in critical organs, or bleeding causing more than 2 grams per DL drop in hemoglobin, or more than 2 units of red blood cell transfusion. Sorry about the typo. The results were that patients, atrial fibrillation patients were diagnosed between 1980 and 2020. About 340 patients were screened and 89 patients were selected for the final analysis. Out of those, 64 patients were female, 28% patients were deceased at the time of the data pull. Median CHA2DS2-VASc score was 3, and 89, so close to 90% had a score of 2 or higher. A third of the patients also had acute coronary syndrome, which the authors lumped together STEMI, non-STEMI, and angina. In the figure over here, as we can see, 42.7% of the patients in the study were on aspirin, or they were ever prescribed aspirin. About 13.4% of the patients were ever prescribed P2Y2 inhibitors. And 56.2% were ever prescribed an anticoagulant. The green color represents people with antiplatelet agents who also had a diagnosis of acute coronary syndrome. About a quarter of the patients were never prescribed any anticoagulant or antiplatelet agent. In these two graphs, we can see the median time to first bleeding event. On the left, we have antiplatelet agents, and on the right, it's anticoagulants. As we can see in both, it looked like the median or the time taken for median first bleeding was greater than 15 years for both of these study groups. Just going into the raw numbers, 10.2 events per 100 patient years. So the rate of major bleeding was 10.2 events per 100 patient years for those on antiplatelet agents, 8.9 events per 100 person years for those on anticoagulants without any statistical difference between the two groups. Baseline risk of bleeding was 1 event per 100 patient years. So these were the patients who never got antiplatelet therapy or anticoagulant therapy. Concomitant anticoagulant and antiplatelet agents resulted in much higher risk of bleeding, which was about 28 events per 100 patient years. The lifetime risk of major bleeding was also calculated by the investigators, which was 32% in those who were ever prescribed anticoagulants and 25.6% who were never prescribed anticoagulants. And there was no statistical difference between the two groups. Looking at the stroke risk, the incidence of stroke was about 15.7%. And notably, 11 out of the 14 patients had never used anticoagulant for more than, had not been prescribed anticoagulant for 90 days or more. The median CHA2DS2-VASc score was 3 in those who had stroke, and also those who are not on anticoagulant therapy. One of those patients who had a stroke had a fatal stroke. So the authors concluded that 50% of the patients in their study group were ever prescribed anticoagulant. There was no benefit in choosing antiplatelet therapy or anticoagulant therapy if a bleeding rate is taken into account. There was no difference in lifetime risk of bleeding in those who were prescribed anticoagulants versus those who were not prescribed anticoagulants. Concomitant use of anticoagulant and antiplatelet therapy has much higher risk of bleeding, which is not surprising. And 15.7% of patients had thromboembolic strokes, most of those who were not on anticoagulant therapy. So my takeaway from this study was that it was one of the largest studies looking specifically at this population of von Willebrand disease individuals who also have atrial fibrillation. It was a retrospective study, so has its own limitations, but it still provides one of the largest studies or largest evidence, which makes us probably feel a bit more comfortable using anticoagulant in these patients with appropriate risk assessment of bleeding. Oftentimes, antiplatelet agents are prescribed over anticoagulants as a way to reduce the risk of bleeding, but this study sort of makes us doubt that assumption. Details of von Willebrand disease subtypes were missing, and as we know, the severity of von Willebrand disease or the type of von Willebrand disease could make a difference to the bleeding risk. We also have noted recently that ristocetin cofactor activity may not be appropriate to diagnose patients with type 2 von Willebrand disease. So some of those individuals were typed as von Willebrand disease back in the previous years may actually not have von Willebrand disease. Similarly, practice patterns for AFib management as well as the choice of anticoagulation has changed quite a bit since 1980s. So that could certainly be a confounder. I'm going to move on to the next. So this was also an oral presentation presented on behalf of Dr. Connors. It was a meta-analysis of direct oral anticoagulants versus low molecular weight heparin for treatment of cancer-associated thrombus. In this study, the authors looked at 6 randomized controlled trials. This was an update to the previous meta-analyses, which had 4 of these trials mentioned over here, the top 4. So the 2 bottom ones were included in this meta-analysis. So there were a total of 3,690 patients, out of which 1,850 got direct oral anticoagulants and 1,840 got low molecular weight heparin. The authors looked at the risk of recurrent venous thromboembolism, and it favored use of direct oral anticoagulants. The incidence rate of recurrent VTE was 5.5% in the direct oral anticoagulant group and 8.3% in the low molecular weight heparin group, with a risk ratio of 0.67 favoring direct oral anticoagulants. Risk of major bleeding was about the same in the 2 groups. So the incidence was 4.3% in the direct oral anticoagulant group and 3.7% in the low molecular weight heparin group. And statistically, there was no difference between the 2 groups. The clinically relevant non-major bleeding favored use of low molecular weight heparin. So the incidence was 9.5% of this bleeding in the direct oral anticoagulant group and 5.7% in the low molecular weight heparin group. The risk was 1.6 and statistically favoring low molecular weight heparin group. All-cause mortality was similar in the 2 groups. The conclusions drawn from this meta-analysis were that DOAC significantly reduced the risk of recurrent VTE compared with low molecular weight heparin without increasing the risk of major bleeding. However, use of direct oral anticoagulants was associated with increased risk of clinically relevant non-major bleeding. Finally, the last oral study that I would like to present was about impact of race and ethnicity on cancer-associated thrombosis among underserved patients with cancer. This was an oral presentation presented by Dr. DaCosta. In this study, a retrospective analysis was done, and the investigators identified 9,353 patients. Out of those, 49.3% were Hispanics, 27.6% were non-Hispanic Blacks, 50.5% were non-Hispanic Whites, and 7.6% were Pacific Islanders. Interestingly, 74.7% were uninsured. And the reason for this was the study was primarily focused on a safety net hospital in Houston, which has this demographic of population. The incidence of cancer-associated thrombosis was 7.3% at 6 months and 9.6% at 12 months. Previous studies which have looked at this, which are primarily focused on Caucasian population, the risk at 12 months is much lower, about 2.3%, so something to keep in mind. On the graph on the left, we can see, as expected, pancreatic, upper GI were the, or patients with pancreatic or upper GI cancers were the ones with highest risk of cancer-associated thrombosis. The interesting part was the bottom right figure, where we can see that non-Hispanic Black population and non-Hispanic white population seem to have similar cumulative incidence of cancer-associated thrombosis at 12 months, while Hispanic population and Asian population seem to have a lower risk. So this contradicts what we have traditionally known about thrombosis, which is reported to be higher in individuals with Black ancestry. Asian and Hispanic population have been traditionally known to have a lower risk of thrombosis. So that is congruent with that knowledge. When the authors did a multivariable analysis, they again found Hispanic race and Asian race were to have an impact on the risk of getting cancer-associated thrombosis. The conclusions drawn were higher incidence of cancer-associated thrombosis was noted compared to the European registries. Non-Hispanic Blacks had similar incidence of cancer-associated thrombosis to non-Hispanic whites. Hispanic and Asian Pacific Islanders had a lower risk of cancer-associated thrombosis compared to non-Hispanic whites and non-Hispanic Black population. And treatment with chemotherapy or immunotherapy associated chemotherapy or immunotherapy was associated with increased risk of thrombosis. And that concludes my talk.
Thank you, Sudhanshu. Just gonna start my, oops, just the right one. Hopefully this is the right one. All right. So let me just start moving. Okay. So hello everybody, and I'm Alex Pine, and I wanted to brief you everybody on 3, potentially 4 abstracts if we have time. The first 3 are sort of have this ITP flavor, and a couple of them has COVID color. So the first one is actually, the first 2 kind of have the same motif, and both studies actually looked into what happens to patients with pre-existing thrombocytopenia when they receive COVID vaccines. And so the first study, which was out of Cornell, essentially they were operating on the premise that platelets play quite a bit of a role in immune system, and also in their cohort, different cohort, but in their center, thrombocytopenia happened in 27% of patients with just COVID-19. So they essentially postulated, or at least kind of developed the concept further, that in COVID-19, especially severe COVID-19, there's a normal glycosylation of the spike protein antibodies is a prothrombic signal for platelets, especially through direct receptor. These complexes of IgG and virus operate through the FCY receptor. And so what they also there was also clinical sort of observation. Then there were some reports of ITP in post-vaccine settings in a single institution, I believe MGH. There was 52 patients, and there were 12% of ITP exacerbations. So they asked the question, several questions. In fact, what is the effect of vaccines on a platelet count, risk of bleeding events, and what kind of effect is in repeat dosing of vaccines, the second vaccine, booster, and so on, and what the risks of the actual exacerbation, what sort of plays a role in ITP exacerbation. So their cohort was retrospective from patients, 10 university affiliated patients. We actually also participated. So it's 117 patients. With a pretty long history of ITP, 12 years. And of course, they were, at the time where the study was sort of conducted, the patients who were getting vaccinated were older patients. So breakdown of what therapies were administered, either on therapy or off therapy, or prior therapy. So TPO, RAs, and rituximab were bulk of the treatments, and splenectomy was also in 21% of patients. And at the time of the study, 48 patients were off treatment, and 16 of those were with normal platelet count. This is a breakdown of the vaccines that were received. Pfizer, Moderna, of course, majority. And then some definitions, how they sort of were assessing the response. So stable platelet count was plus minus 20% of the pre-vaccine level, and ITP exacerbation was defined as either more higher than 50% reduction of platelet count or 20% reduction if the nadir of platelets below 30,000, or the use of rescue treatment. And so what they found that there's three groups of patients. So in about I would say third, or close to third, maybe quarter, the platelets actually increased. Platelet count increased in middle part, like a 40%, nothing happened, and in about thirds, so to speak, it's actually decreased. And this is the first dose, this is the second dose, sort of similar. And they pointed out that it may not be the same patients. So they broke it down into several groups. Specifically, so they assessed all patients in terms of incidence of post-vaccine ITP exacerbation, splenectomy, patients with splenectomy, and patients with very heavily pretreated with more than five and more prior therapies. And so, interestingly enough, if you look at the splenectomy, it's they saw a significantly higher incidence of platelets of ITP exacerbations, as well as patients who are very heavily pretreated. Now, when the post-vaccine rescue therapy was administered, it was effective. Was administered about 30% of patients, and they reported no serious bleeding events. Patients with stable or increased platelet count after the first vaccine, so those 43 patients, and after dose number 2, 6 patients have platelet count decreased below 30. So factors that they found not predictive of ITP exacerbation were age, gender, vaccine type, and presence of autoimmune disease. They actually had access to 2 surveys, and they sort of tried to validate their findings, and they looked into these surveys. These are 2 surveys. One is from based in the United States, one is from UK. Essentially, they track the similar data, and so they found that indeed in patients who had platelet count decreased, the there were a lot more people with splenectomy. And then when they looked into a UK ITP cohort, also survey based, they found sort of breakdown of similar breakdown of decreased platelets. About a third of patients indeed had ITP exacerbations, and they also, in the same survey, they found that splenectomy was associated with a twofold increase of risk of decreasing in platelets by more than 50%. So they acknowledged the few limitations, that there's no lack of there's no unvaccinated control group to compare. There was a possible selection bias because they were following a lot closer the people who had refractory ATP already. They didn't account for titration, for concurrent sort of interventions in terms of how they affect the platelet count, including the titrations of the medications of the treatment that the patients were already on. And they acknowledged that the possible overlap between cohort might affect the platelet count. But overall, they felt that the major point was that there was no bleeding in refractory TCP, in the refractory thrombocytopenia following vaccination. And the major sort of point out there was like, if it's a splenectomized patients, follow closer. If it's a patient with a difficult control ITP or heavily pretreated, follow them closer. And so that was main idea. And then in the post in an additional question sort of session following the abstract presentation, somebody was asking how would you consult patients and who actually perhaps did not, who had a thrombocytopenia after the first vaccine, would you give the second vaccine? And so the presenter actually said that she usually she would actually recommend, but with a close observation. All right, so moving on to the second one. So the second study was similar. In fact, they just followed one another. This one is from this is a Dutch study. The benefit of this study was a prospective cohort, but the question was fairly similar to what happens in patients with ITP, with pre-existing ITP when they receive COVID-19 vaccine. This study had a control arm. It had about a similar, actually twice as much patients, 218. In about the same number of 200 healthy controls. Breakdown of vaccine was a little different. Most of them received Moderna, that was in Holland. And all healthy controls received Moderna. 15 patients required rescue treatment. Now, this is a breakdown of the treatment that patients were received or were on. So quite a number were on steroids at a time, and then also about 10% were had splenectomy. Definition of ITP exacerbation was fairly the same, in fact, exactly the same. And so what they found here on the graph below is that the both platelet count in both normal controls and in patients, ITP patients, actually decreased, and they, I believe they said it decreased by 6.3% in both groups. So they didn't really feel there was a difference in reduction, but they both platelets in both groups went down. In fact, this is the better image of that. And so they further looked into risk factors as well. And here they found interesting piece, which is contradicts the previous study. They found that splenectomy actually was associated with increase of platelets, quite a substantial increase of platelets. And current treatment was associated with a decrease of platelets, and age was associated with small decrease in platelets following vaccinations. So this is again sort of a tally that 30 patients developed exacerbations, 15 required rescue treatment. The bleeding, they did report bleeding, and interestingly enough, in a post in the question period, they were asked about this. so all the 5 bleeding episodes happened in patients with platelet count of higher than 100,000. And in fact, one patient who had a fatal gastrointestinal bleeding also had platelet count of 100. So their answer was that it was not related to vaccination at all. It was comorbidities, and in fact, in the patients who had a GI bleed, fatal GI bleed, it was a severe liver disease. A few patients required transfusions of platelet or red blood cells. So the conclusions here is actually kind of similar. The effect of COVID-19 vaccination was similar in healthy controls and ITP patients. Exacerbations were only in a few ITP patients. There was a good response to rescue treatment. And essentially, vaccination is safe and monitoring is advised, as actually was recommended by ASH guidelines. And this is sort of the additional questions that they were asked. Somebody asked whether they checked for platelet antibodies, and they said they did not evaluate for platelet antibodies directly, but there's no association with IgG levels in healthy controls. So I want to just finish up with this third study, which is also ITP related study. And in fact, this is an interesting trial about use of BTK inhibitor rilzabrutinib in refractory relapsed ITPs. The premise of the trial was I think it was phase 1, phase 2 sort of update on the phase 1, phase 2 trial. The premise was that BTK inhibitors modulate quite a bit of quite a number of different effector cells, B cells, and macrophages, and also signaling of the B cell receptor. And inhibitors decrease autoreactive antibodies, and so there's an interest in evaluating this group of class of medications, class of drugs in ITP, and specifically why rilzabrutinib was chosen, because is believed to be very selective. So out of different kinases, it's pretty selective. It inhibits BTK quite nicely, but not others. Or rather, occupies BTK target quite nicely, but not others. It's quite reversible. And why not ibrutinib, for instance? There's association of platelet aggregation with ibrutinib, but not rilzabrutinib, as shown here when was tested against collagen. So much essentially associated with aggregation more than rilzabrutinib. So the trial inclusion criteria was fairly straightforward. It's response. It's actually adults response. They had to have at least response to one prior treatment, and there's no other treatment available to them or not approved. And there should be at least 2 platelet count less than 30,000 rather on 2 occasions, and concurrent therapies were allowed, including corticosteroids and TPO-RAs. There was a dose escalation as a phase 1, but in kind of a phase 2 phase of it, part of it, they used actually 400 milligrams BID, which I'll show soon. Primary endpoint was essentially platelet count of greater than 50,000 on 2 occasion, at least an increase of 20,000 off the baseline without use of rescue medication. And they actually had a long-term extension also for 400 milligrams of BID. And so here's what happened. So this is kind of an overall study diagram. So this is the 400 BID group. So this is 45 patients. And so here's the results. So out of this 45, 18, that is 40%, reached the primary endpoint. So greater than 50, and with 20, greater than 50,000 increase, greater than 50,000 platelet count increased 20,000 from the baseline. So that's 18 patients reached that endpoint. And it was very rapid improvement. So this is it's probably hard to see, but this is days. And so within, this is actually 20, I think it's 25 or 29 days. So it's a really rapid improvement, and it's actually sustained. And of course, these are not responders. And you can see here that this is sort of a better way to assess sort of duration of response. So this is greater than 30 number of weeks achieved in 20 and greater than 50 in 14. So then, oops. And so they made a point that it's indeed a very rapid increase. In fact, median time to greater than 30,000 level was achieved in 8.5 days, greater than 30,000 plus 20,000 above the baseline in basically 12 days, and greater than 50,000 platelet count in just about the same 12.5 days. And median time to the primary response was about a month. So it's very, very rapid. And then they also showed the what happened in this long extension or arm, so to speak, and they said that it's basically it was quite robust, especially it's a maintained the response. All right, and then adverse effects. Basically, it's all grade 1, grade 2. Diarrhea, nausea, fatigue. And again, this is all about 400 milligrams twice a day. So conclusions that risabrutinib provides inhibition of phagocytosis, and 40% of patients on 400 milligram BID achieved primary endpoint, the 18 patients. Response was rapid and was well tolerated, and response was maintained. So there's an ongoing phase 3 LUNA-3 trial, which further will address this modality. In additional questions, I think there was nothing really particularly interesting, but they said nobody was on any antibiotic prophylaxis, and there was no infections. So I think in interest of time, I stop here. If we have some questions.
Well, thank you all very much for those very informative and very clear presentations. If people do have questions, if they could put them in the chat, there are a couple there. Maybe we can start with those. So Kelsey, you mentioned in your abstract with factor 11 deficiency that some patients bled despite getting fresh frozen plasma. What might be some alternatives to treat those individuals, or do you have any thoughts about why those people still had bleeding?
Yeah, it's interesting. I mean, the half-life of factor 11 is long, I think about 2 days or so. And so it's intriguing, but I think something we've all experienced in practice. I think that may happen, perhaps just the quantity of factor 11 and it's not concentrated. You never maybe know exactly what you're getting in the FFP, maybe one element. And there are cases reported of inhibitors. So perhaps some of those patients that didn't respond maybe had inhibitors. I think that Novo 7 could be used, but I think with caution, maybe at a lower dose, or maybe particularly in someone who had an inhibitor, I think there would be a role there. And then maybe sort of leaning more heavily on antifibrinolytics might be useful. But I mean, I think it's a challenge we've all seen and experienced that sometimes is hard to pinpoint. It's a great question.
Great, thank you. Thank you. And Sudhanshu, you mentioned that there was an increase in the clinically relevant non-major bleeding in individuals who are getting DOACs for cancer-associated thrombosis. So when you prescribe either a low molecular weight heparin or a DOAC to a patient with cancer-associated thrombosis, how do you decide on the benefits risks there, and what agents do you tend to choose, and are there things about the patient that may point you in one direction or another?
So the clinically relevant non-major bleeding was really of concern, which was higher in DOACs, and that has been pretty consistent throughout all the 6 trials, so it wasn't just one study. And the way it impacts my practice is if I do look at the patient's underlying bleeding risk, if there is an individual where I would be more concerned about bleeding, perhaps someone who had immediate post-operative thrombotic event, or perhaps with somebody who's going for a surgery or who has a known history of underlying bleeding or falls, I might be more inclined to use low molecular weight heparin in those individuals rather than DOACs. So that would be my approach and how I would use that information.
Thank you very much, Sudhanshu. And Alex, are there any situations in patients with ITP in which you might hold off on giving COVID-19 vaccine? So individuals who are recently flared or have very low platelet counts and requiring intense therapy, for instance?
So this is interesting because the data, they really didn't actually include specifically, like, they didn't address the question of whether patients who were right now on in active ITP exacerbations prior to vaccination, they only had patients who were on sort of chronic therapy. So I don't think we have data per se in that regard. But personally, I think if there's a flare, ITP flare, I probably would hold off, just not to disturb immune response further. I think what might be really interesting is in this situation to address further whether they're truly platelet antibody, which none of them really looked into.
Great.
But I think I would probably hold off until there's some stabilization of platelet count.
Seems very prudent. Yep. Okay. All right. Well, it's just about 1 o'clock. So I want to thank our speakers for, again, excellent presentation that were informative and I think highlighted some really important areas in classical hematology. And thank you all for joining us. Thank you very much. Have a great day, everyone. Bye.
Thank you.
Thank you.